is IgG4 related diseases of the head and neck. I picked this topic because it's a topic that you can really cover in 1 hour, and it's something that should be the part of our differential diagnosis in tumor boards of the head and neck. I mean, it affects the whole body, but it also has application in what we do every day. So let's get started. So what we're talking about is an immune-related condition that affects many different organs, so that it comprises a group of disorders with a common pathologic, serologic, and clinical features. It's essentially fibro-inflammatory lesions that are rich in IgG4 positive plasma cells and can, most of the time, present also with elevated IgG4 concentration in the blood. So one of the tests you can do other than biopsy is the IgG4 serum IgG4 levels. So that's one thing that helps with diagnosing it, although it doesn't have to always be there. And so what we're dealing with is infiltration of these plasma cells, lymphocytes, and associated fibrosis, and it produces something of a tumefactive appearance in the organs that are involved. There are multiple diseases that previously had IgG4 related pathologies, and they had different names like sclerosing disease, systemic disease, autoimmune disease, plasmacytic syndrome. All of these diseases have come together. The clinical exam shows diffuse or localized swelling or mass in one or more organs. And if you look at it under the microscope, you can see infiltration of lymphoplasmacytic cells and what we call, I have a picture for you, for what we call storiform fibrosis. And there's infiltration within the organ. So it's an infiltrative type disease. This is one example. This is lymphoplasmacytic infiltrate. This is Rydell's thyroiditis. As you can see here, these cells are the infiltrates, these really dark nuclei. Now, I'm not a pathologist, but the arrows help me out. So these are the really larger nuclei, and this is the rest of the thyroid. And if you stain for IgG4 positive, if you stain these big cells here, these dark blue cells with IgG4 stain, they give off a brown color. So that is one of the diagnostic hallmarks of it. This is the storiform fibrosis picture. So this is your normal thyroid, the colloid cyst, the colloid lobules in the thyroid gland here. And then this area here is your infiltrate and surrounding these lesions. And so this is one appearance. And the third appearance is the obliteration of venous channels by IgG4 positive plasma cells. So one of the things as I go through this talk, I want you to remember, just think of it from the histologic. This is a very strange thing for a radiologist to say, but think of it from the histologic perspective, and the images will make a lot more sense. So here again, this is infiltrate into a vein by, lymphoplasmacytic cells, all IgG4 positive. This is supposed to be, the lumen of the vein here, and this is just, just deep to the lumen. So again, all these different things that were called IgG4 related diseases that are now called IgG4 related diseases, these are all the same, so instead of having, multiple different diseases, we just call it under one umbrella, IgG4 related diseases. And it affects many organs. Like the first organ, for example, the first organ that was actually identified with this autoimmune pancreatitis with IgG4 related disease causing autoimmune pancreatitis was obviously the pancreas was the first one, but later on people discovered that not just in the head and neck, but all over the rest of the body, which sometimes is important for us to look at the rest of the body to figure out what's going on in the head and neck. This is one example. So it's similar to autoimmune pancreatitis, and it involves things like bile ducts, gallbladder, lymph nodes, retroperitoneum, mesentery, kidneys, lung, breast, prostate, skin. This is an example here of all the different things that are involved, like pachymeningitis, hypophysitis. For example, that was a case that Dr. Enam had last week, I believe. Orbital pseudotumor. The thing with orbital pseudotumor is that that's supposed to be painful. Everything else is not painful. So that's just one little caveat. The most commonly affected organs are in the head and neck. The most commonly affected organs are the salivary and lacrimal glands, the orbits, the sinonasal, the larynx, the thyroid gland, the pituitary, and the meninges, and the meninges mostly the pachymeninges. And furthermore, lymph nodes can also be involved. So for all the world, this could look like a malignant process, but it's not. So, one thing you can do is to look at the CT of the abdomen. I mean, certainly if you have autoimmune pancreatitis, hopefully someone has imaged the person. And it's present in most patients with IgG4 related disease. So your pancreas could be the defining thing if you haven't biopsied or have any lab values or anything, and it could sway you toward it, but you don't have to have pancreatic involvement. And extrapancreatic lesions can develop before or after, and there's a large latency of time in which you can get disease outside of the pancreas before or after you get autoimmune pancreatitis. So it can take years. I mean, in one source said 15 years. But as you know, this is not necessarily a disease that's really, really well studied, because there isn't, a ton of a plethora of, like meningiomas or something. There isn't a plethora of cases that you can look at. So just bear in mind that, there is a lead and lag time with getting extrapancreatic disease. So one of the things that's the salivary and lacrimal gland involvement. The trick here is bilateral painless swelling of gland. The gland is bigger than what you'd expect it to see. And you all know what that is, because you all look at your CTs and your MRs, and you look at the orbits and everything, and the lacrimal glands and submandibular glands and all of that. And one telltale sign is if there's more than one gland involved. Like you could have one parotid and one submandibular gland, or the other way around, or both parotids, both submandibular glands, or all four of those glands. The thing to remember is that on imaging, you have homogeneous low attenuation with enhancement. The one thing that many sources don't talk about is that if you look at the organ that's involved, it's featureless. Because you have infiltrate coming in, just like if you have infiltrate coming in, like a glioblastoma that can reach up to, or any other glial type tumor that can reach up to the gray-white junction, and it can reach all the way down to the corpus callosum, you lose features of, like, where does this begin? Where does this end? You lose the lobules, just like you would lose the lobules in the pancreas, the acinar portions of the pancreas. You can't differentiate, you can't draw like a pencil mark around those lobules because there's so much infiltrate and it goes everywhere in that gland. It gets very hard, so it becomes featureless. And because you have, remember, these cells were large nuclei cells, so there's less water, so there's less T2 signal. So it's darker than CSF for that reason, because you have large blue cell tumors. And for that same kind of idea, they can be bright on diffusion, just like lymphoma is bright on diffusion. For all the world, it could look just like lymphoma. But that's one other telltale sign. And as we said before, it can occur before or after pancreatitis. So there's some differential here. You have, like, if it involves glands, obviously Sjogren's, painless enlarged lymphoma, right? But you have to have an index of suspicion, because most of the time when we think of infiltrative, inflammatory type of lesion, you're dealing with pain. but here it's infiltrative, and it's not like there's not a lot of neutrophils or anything like that in this thing, so it's painless. And if only one gland is involved, you have to exclude malignant salivary gland tumor. But remember, this thing usually involves the whole gland, right? And the gland is enlarged. You don't see any discrete mass other than the gland being big. And I have from this point on, we have pictures. So this is sialadenitis related to IgG4 related disease. You can see enlargement of the parotids. The arrows point to the, see how this is featureless? This parotid and this parotid, they're featureless. You can barely tell where the masticator space starts. And it's all because it's all infiltrated. And sometimes you can barely tell where the ducts are in the parotid and submandibular. And if you have a good MRI scan, even the sublingual glands. It's very hard to tell that. So featureless, somewhat enlarged, but something like this isn't as obvious. You know, if they say, oh, this is a little swollen or something like that, you may end up doing a biopsy, or many people might blow this off. So you have to have an index of suspicion for painless, enlarged parotids, dry mouth, that kind of stuff. And when you do a PET scan, it is, in this particular case, they're mildly hypermetabolic because these infiltrative lymphocytic cells, they need sugar, right? So they need more sugar than your average other structures, you know, the muscle and that. Here's I think this is the soft palate here, so that's fine. But the gland here, you know, the sublingual gland here is a little enlarged, just like the parotid. And so there's mild, in this case mild, but it can be more. And here the one big thing that shows here's without and with contrast. Yes, it does enhance, but the gland itself enhances normally anyway. But the size makes it suspicious. I mean, these are very, very large. It's easy to blow over, you know, and ignore it because it's symmetric disease, but you're dealing with what you would expect would be, for the most part, symmetric anyway. And note how featureless this is. You know, you don't have all the nice lobules, and the enhancement is, you know, different, but there's no discrete mass. So this is, again, an IgG4 type process. It can involve the orbit with the lacrimal glands. Any part of the orbit can be basically involved. And some people feel that this may be a precursor for orbital lymphoma. And again, orbital pseudotumors are associated with IgG4 related disease, which can be unilateral or bilateral or involve any portion, including the optic nerves. So here's the one thing to keep in mind, because it can involve anything. You can get perineural involvement, and for all the world, you might think this is, I'll show you some cases that you might think these are like squamous cell carcinoma with perineural spread. You know, it involves branching of the trigeminal nerves, you know, going up Meckel's cave or going foramen rotundum. So on MRI, low signal on T2 again, and then it's bright on diffusion because these are highly cellular processes and the cells have big nuclei, less water in the cell, less cytoplasm. And so it's less fluid and darker signal on T2. Here's one example of it. So here's a lacrimal gland that's asymmetrically enlarged, and you know, it involves more than the lacrimal gland, and that's another telltale sign. This lacrimal gland, you could draw a pencil around it and say, this is, I can actually draw this gland right here. This one, good luck. It goes all the way up here, down, who knows exactly. And down here, so it's much more ill-defined. The margins are more ill-defined. And here's the example, and then they biopsied this person for dacroadenitis. Here's another example. These are two enlarged parotid glands and salivary glands. And as you can see here, oh, hold on. All right, so you can see that the lacrimal glands are also involved with those cut off arrows in the top right picture, and they do look symmetric. And in this particular case, you have enlarged sublingual, submandibular glands. You know, it's involving more than one gland. So you know, maybe early Sjogren's or something, but they're very featureless glands, and these parotids are here as well. I mean, they're featureless, and they kind of look like the muscle because they're darker on T2. And this is the one I was hoping to show you. You have perineural spread of disease here, the inferior orbital, superior orbital, which, you know, the source that I got this from called it a frontal nerve, infraorbital and frontal nerves. There's involvement here surrounding the optic nerve, outside of the optic nerve sheath. So this is all intraconal. Here it is right here. There's the perineural spread, and here it is in the soft tissue. It's enlarged. Here's muscle involvement. So it can do that, but it can also, here's another appearance of it. Here it is right here in the orbits in a symmetric way right here. It's outside, it's involving the lacrimal glands and going backward. So this type of infiltrative process can do that. Again, the nerves are involved here, you know, the frontal nerves. Here's another inferior orbital nerve. Here's muscle involvement. That's why some people, but this is different than, you know, what you get in Graves' disease, where it's the muscle bellies that are involved. That's a different thing than this. But interestingly, you can treat this with basically high dose. The most common treatment for it is high dose steroids. And so here's unilateral disease here. This is the submandibular gland right here, enlarged, again, featureless. T1, you know, T2 dark, enhances, featureless, enlarged, painless lesion. These are other examples of the same thing. Lacrimal gland is enlarged in comparison to the other one. The one nice thing about radiology is the other side. You know, you look for symmetry. So, and if one side is normal, then you can compare it. There's involvement here as well. You know, this is orbital pseudotumor. Again, this is painful. And it's surrounding the optic nerve, intraconal. It can actually extend extraconal here, as in this particular case. There's proptosis of the left globe. So it's a space occupying infiltrative process. And here's, well, the lacrimal gland here and here as well, but here's involvement. This study is obtained without contrast. The pituitary is a bit enlarged, not very much, but it's the pituitary stalk that is very significantly. I mean, its pituitary stalk is very thin structure, very, you know, elegant kind of structure. And there's also the, you know, the perineural spread that we could see. Here it is again. Just a smaller, but and you know, so it can result in a variety of clinical, like sickness and diabetes, sickness and dizziness. You know, if you can't move your eyes because of muscle involvement or nerve involvement, you do get dizzy, and sensory issues as well. Parotid and height, here it is as well. This is the height. See, again, it's thickened. In a child, I mean, you might think it's eosinophilic granuloma or something like that, but in an adult, especially with parotid and, you know, glandular involvement, the most common thing is the submandibular gland in the adult involvement for the IgG4 related in the head and neck. So when you see that and you see pituitary, consider IgG4. Again, here's extraconal involvement. This is just to show you the plethora of ways that this disease can manifest in a patient. Here's pachymeninges, pachymeningeal thickening. Of course, there's a differential for this. Your typical lymphoma, shunting, someone had a spinal tap or something, or spinal shunt can also give you this type of appearance. But if you look at this, the brain isn't really, well, if I had the right pictures, the brain isn't sagging, and they don't have a history of lumbar puncture or anything like that. So it can result in mild, at least in this case, mild pachymeningeal thickening, but other things might clue you into this disease. Here's sinonasal involvement. Maybe somebody would consider this to be early Wegener's disease, but so your IgG4 in your serum would be very helpful. And if there are other glands that are involved in a small, fine needle aspiration biopsy or something might be helpful. So going to other organ that's involved is the thyroid, thyroiditis, Rydell's thyroiditis, and fibrous variant of Hashimoto's thyroiditis. So you have for Rydell, you have a rock hard painless mass. And again, look for other organs that might have it, might have IgG4 related disease. That might be helpful. For Hashimoto's usually painful. But there are some variants of it that are indistinguishable from IgG4 related disease. Here's an example. So this is an ultrasound of the thyroid. This is your trachea. You all know this, isthmus, left lobe, and maybe a small nodule or something there, but a big infiltrative mass. It's expanded the right lobe of the thyroid gland because of its lymphocytic infiltrate. And the one thing you notice about it is it becomes dysmorphic. It's sort of like slow moving water, it encircles things. It can push things too a bit, but it really can encircle things. So that's the one thing that you see. It's an infiltrative, it's uniform, featureless type of involvement. And here it is again here in the thoracic inlet, and it's encircling vessels, and you can see it nicely in the thoracic inlet, and the trachea is maybe some deviation, but this is Rydell's thyroiditis. And then if you do an FDG PET, it takes up a lot of sugar because of its, these are metabolically active cells that are infiltrating in there. So that's the thing. And here it is in the thyroid gland. So again, this is to point out how typical it is to have involvement of the submandibular glands. And here, your thyroid gland is featureless here. Where does it begin? Where does it end? You can kind of make out, margin where the strap muscle is and where the thyroid gland is, but it's not as clearly defined as in a normal person's normal CT soft tissue neck without or with contrast. Now remember, without contrast, you have iodine and thyroid. You should be able to see your thyroid gland pretty well even without contrast. Here's a great example of IgG4 related disease of the larynx. The one thing that's interesting here, I have to point out, look at the mucosa of the true cords, right? There's nothing there. Squamous cell carcinoma starts from squamous cell cells, and it works its way deep and backward. And the fat here, the periglottic fat, just below the vocal cords is clear, but you have this lesion here. So this is not, if ENT does endoscopy and they say the mucosa is absolutely clear, and especially if they take random biopsies and there's nothing there and you still see this, then you can consider IgG4 related disease. It's not a big mucosal issue, but it can involve anything. But in this case, we have to wonder what else this could be. So here it is. It's hypermetabolic there. Here's some lymph nodes that are involved. Again, these are ill-defined. It's like the lymph nodes sort of melted together because of the infiltrative disease. Where does one lymph node start and one lymph node end? Hard to say, but it encircles vessels. It doesn't necessarily compress them, but it encircles them. And there's disease here as well with some mass effect. So that's what we expect from that. So now we go to differential. We go to some differential. When you see lymphadenopathy, only lymphadenopathy, then you have a differential. But you can also have concomitant lymphadenopathy with IgG4 related disease. And it could be the initial manifestation, but usually discovered in a known patient with IgG4 related disease. So again, autoimmune pancreatitis, salivary glands, those are the two big organs. If you do see involvement there, it should be high suspicion. And the lymph nodes, they're basically everywhere: cervical, axillary, mediastinal, intra-abdominal. There's, interestingly, one thing different from lymphoma is there's no fever or weight loss. This is not a cancer. Lymph nodes are usually less than 2 centimeters, but no sclerosis or phlebitis usually. But the differential includes like other things like low-grade infections, perhaps something like Castleman's, like lymphoma and disseminated malignancy also in the list. Here are some lymph nodes, again, confluent, all matted together. Can't tell which lymph node is what, where they are because of the nature of the infiltration. Again, here, and we could see it also as well here in the subcarinal and, just posterior to the left main stem bronchus and anterior to the precarinal here. Prevascular spaces are involved, so it can involve the mediastinum. Here's some more of IgG4 related diseases. Non-specific involvement of lymph nodes. I think on most days, a lot of people might even pass some of this to say, they're just reactive lymph nodes. But if you think about it, IgG4 related disease is kind of like a reactive disease. So that's one thing. I mean, you give them steroids, they should shrink. And so just show you a normal pancreas. Nice, if there was this MRI of it. So, we see liver, spleen, muscle here, but this is your normal pancreas. You can kind of see lobulations of the acina. In the newer scanners with better protocols, you get better pictures of it. But here, you can see how featureless it is. And then there is some enhancement for this IgG4 related disease. And that's all I have to say about that. So I hope I haven't put everyone to sleep.